Look at the text at the top right of this page. The prognosis for carcinoma of the esophagus is explicitly described as dismal, noting a 5-year survival rate of just 5 to 10. Making sense of that single-digit survival rate requires mapping the cancer's silent physical expansion long before it triggers a patient's first warning sign. From a clinical perspective, esophageal cancer is a deceptive umbrella term. We are actually dealing with two distinct diseases, each driven by entirely different environmental risk factors. The first and globally dominant pathway is squamous cell carcinoma. This diagram illustrates its specific geographical footprint. The bracket indicates 90% of these specific tumors occur across a wide vertical stretch. Breaking that down, 20% form in the upper third, 50% in the middle third, and 30% occupy the lower third. These tumors originate in the flat squamous cells lining the tube, triggered by repetitive surface-level chemical and thermal irritation. Looking at the etiology listed here, the primary culprits are heavy smoking and alcohol consumption, along with specific nutritional deficits like Plummer-Vinson syndrome. But there is a second, rapidly rising pathway, adenocarcinoma. Unlike squamous cell tumors, adenocarcinoma has a hyper-specific territory, localized almost exclusively at the very bottom junction where the esophagus meets the stomach. This specific location is vulnerable to a completely different chemical threat, gastric acid splashing upward from the stomach. Chronic acid reflux forces the native esophageal lining to mutate and adopt an acid-resistant cellular structure, Barrett's esophagus, which frequently degrades into aggressive malignancy. Despite having completely different chemical triggers, top-down irritation from smoke and alcohol versus bottom-up damage from stomach acid, both pathways ultimately converge on the same result, the rapid structural collapse of the esophageal tube. Once the cellular mutation begins, the clinical problem shifts from how the tumor originated to how it physically occupies space inside a hollow organ. These illustrations show 3 morphological tumor forms. The top polypoid form is an exophytic mass, acting as a physical roadblock choking the passageway. The middle ulcerating form erodes deep into the wall, excavating bleeding craters. Finally, the diffuse form infiltrates circumferentially, stiffening the tissue. This diffuse spread physically stiffens the muscular layers, stripping the organ of its natural elasticity and converting a highly flexible swallowing tube into a rigid, non-functional structure. Whether the tumor protrudes, excavates, or infiltrates, the inevitable mechanical consequence is total obstruction of the lumen. Most gastrointestinal organs are encapsulated by a serosa, a tough outer layer that acts as a physical containment wall. The esophagus is the anatomical exception. It lacks this barrier entirely. The text here highlights the consequences. Without a serosal boundary to contain it, a growing tumor faces zero anatomical resistance against direct transverse spread into surrounding structures, like the trachea and mediastinum. This unrestricted lateral breach immediately compromises critical adjacent tissues, frequently carving destructive fistulas directly into the airway and severing the nerves controlling the vocal cords. While the lateral invasion is devastating, the spread along the longitudinal axis is often much faster. Just beneath the lining sits a dense network of vertical lymphatic vessels. Tumor cells exploit these channels to travel with almost no friction. Microscopic cell clusters are deposited far above and below the primary tumor, establishing new satellite colonies in the neck and diaphragm. These aggressive lymphatic colonies form rapidly and silently in the background, well before the cancer has the opportunity to breach the circulatory system. By the time the tumor accesses the bloodstream to reach distant organs like the liver, the patient is already facing late-stage disease. Because of this unchecked transverse invasion and rapid vertical lymphatic transit, a tumor that appears small and isolated on an initial surface scan has almost certainly compromised the deep structures of the chest and neck. While this aggressive structural collapse is happening at the microscopic level, the patient remains entirely unaware until a distinct physical threshold is crossed. The primary diagnostic signal is recorded right here: dysphagia or difficulty swallowing, and crucially, it is marked as painless. It presents as a slow, progressive mechanical failure. Patients first notice meat or bread getting stuck, a problem that eventually worsens until they cannot swallow water. The absence of pain during this early progression is the primary reason patients delay seeking treatment. The human body uses pain as an urgent alarm system. Without it, severe physiological changes are easily dismissed. Dysphagia is a mechanical symptom. As the tumor grows, the elastic esophageal walls stretch outward, widening to maintain a passageway and mask the obstruction. It is only when the mass exceeds this stretch capacity that the channel narrows, trapping food. The mechanical threshold required to physically obstruct a tube that elastic is immense. By the time a mass is large enough to noticeably impede swallowing, the rapid local invasion and lymphatic permeation we mapped earlier are already complete. This 5 to 10% survival rate reflects a fundamental mismatch between the timing of symptoms and the speed of anatomical spread. By the time the organ exhausts its capacity to stretch and signals the patient with dysphagia, the window for localized intervention has likely already closed.